Tell me when. Good evening. I thank you all for tuning in today for Global Health Conversation with Dr. Paul Farmer, brought to you by Stanford Center for Innovation in Global Health. I'm Michele Barry, the Director for the Center for Innovation and also Senior Dean for Global Health at Stanford. I'm extremely excited today to introduce our guest, Dr. Paul Farmer. But before we get to Paul, I'd like to introduce another Paul, the wonderful Paul Costello, who will be leading our conversation. For 17 years, Paul has served as the Chief Communications Officer at Stanford Medicine, and then as a Senior Communications Strategist. He's a fantastic communicator and a very skilled interviewer. And he's our center's global faculty conversationalist. Currently, Paul teaches a medical school class on leadership and is contributing editor for Stanford Medicine magazine. Thank you so much for being here today, Paul. Now, where to begin introducing Dr. Paul Farmer? I met Paul many years ago. He probably doesn't remember, but maybe does, in 1987.
Decades. I was going to say decades, my dear.
Yeah, 87 or 88, where I was teaching at Yale, and he came down to a student's house to actually share his views on social justice, and also describe this really small nonprofit for treating patients with HIV he was co-founding in Haiti, which he was calling Partners in Health. Well, the rest is history. And in the world of global health, he is famous not just for his incredible work, but also for his masterful ability to tell stories. His stories and the stories of the hidden millions struggling to overcome the world's health obstacles. We started a few minutes late because he was actually teaching a high school class. So he's still spreading that word. As a doctor, Dr. Farmer has devoted his life to bringing high quality medicine to those most in need, no matter the circumstance, advocating for a preferential option for the poor. And as a medical anthropologist, he's brought awareness and action to fighting structural violence and racism and its devastating impact on human health. As a leader and co-founder of PIH, he's expanded what was once that small project he described in Haiti into a global NGO, building medical infrastructure and health systems in parts of the world neglected and forsaken by so many. And as a storyteller, Dr. Farmer has given global health a voice, never failing to reflect on the forces that shape health outcomes around the world and shine a light on the populations and people that have suffered too long in obscurity. Most recently, Paul wrote a book. He had a fabulous book written about him by Tracy Kidder, but he's now written, along with other books and publications, a book called Fever, Feuds, and Diamonds, a historical account and analysis of the 2014 West African Ebola outbreak that serves both as a timely call to action and a tribute to those who perished and bravely served at the front lines of global health. I have to now say thank you, Paul, for joining us. And just some of the logistics. He's here to actually discuss his new book, his career, and the myriad health issues facing the world today. I do want to leave 20 minutes, Paul and Paul, for Q&A that I'll try to moderate. So I know this interview will be fascinating, but I'm asking anyone who's watching, and I believe there's like almost 700 people, I welcome you to drop your questions into the chat, and we will try to get to as many as possible. And with that, I hand it over to Paul Costello.
Thank you, Michele, and thank you, Paul Farmer, Dr. Paul Farmer. I'm really honored to talk to you today. I thought it was very interesting that you just spoke to a high school class. So you're coming here from a high school class. I wanted to ask you about that. But I was really interested at the beginning of a recent Zoom interview. You asked a Time magazine reporter, am I allowed to be a normal person, and ask, how are you? So I want to begin there. How are you?
Thank you, Paul. I'm great. I mean, after that introduction by Michele, of course, my ego is inflated, but I'm doing fine. You know, it's been a year like no other for all of us, and you know, it certainly put a crimp on things like teaching in person, whether high school students or my usual students or medical students and clinicians. But it's, and I'm watching what's happening in the United States with some anguish and concern. I've lost people with COVID, family, friends, patients.
Who in your family did you
My
lose?
father-in-law died in June.
Mhm.
And, and so many others, like I said, this is my friends, family, patients. And, I've never really lived through a pandemic like this before. And I think very few, I think that's true of certainly of the high school students I was just speaking with. I mean, they, just thinking there they are, it's 8 o'clock at night on the East Coast. They're in a high school auditorium with masks on. What a strange
Hmm.
experience, very disturbing experience. But you ask me how I am, and now that I recall that conversation, the person interviewing me for Time Magazine had been a Knight Fellow, Knight, at MIT, and she'd taken a class of mine. So I felt like she owed me more than just launching into an interview. I said, "Wait, Jamie, how are you?" So there was that part of it too. But I'm as they say in these parts, I'm hanging in there, and trying to remain optimistic. And but like I said, this is a concerning time. I just still having a hard time getting my head around the fact that we've lost close to 500,000 people here.
Right.
And
You said recently something that I thought was really, it gave me a window into you much more so than the words you said. And you said, I never shame people for wearing masks. It's not the way I roll. And I found that interesting because it struck me that you were saying something much larger than that about masks. I interpreted it as your worldview and how you view public health. And do I have that right? Is that sort of
yeah,
what you were saying?
exactly, Paul. What I was saying was not about masks. It was really about, does shaming work in public health? Uh, you know, whether we're talking about smoking cessation or obesity, there's so many negative examples of the stigmatizing effect of shaming. Does it work? Does it work to shame someone publicly when they're not wearing a mask? There have to be better ways of doing it. I will say I was in Rwanda for the month of August. This is a place Michele and I have been together. And one of the things that really floored me was in rural areas. Partners in Health works in rural areas, is that everybody was wearing a mask.
Hmm.
And, I could have said, hey, you don't really need to be a mask. Wear a mask. You're sitting outside in the sun, Of course, I didn't say that. I didn't say anything. But, there have been times when I see someone without a mask in the United States and, maybe I'll offer them a mask. Or what happens to me if I get out of the car to run into the grocery store, I'm sure I'm not alone in having forgotten my mask. And then someone will say, hey, you forgot your mask. That's not shaming. So I was really trying to get at a deeper point about, and I have to, Paul, you're bringing this out of me. This is why they call you the conversationalist. I was also thinking about the people whose views I just don't understand, political views, in the United States, country
Correct.
I was born and raised. And I have to say, I've found a lot of these views disturbing, racist, and much more. And, and I just realized, am I too distant from even my own roots to try and sort out why people would, have such convictions? I mean, I can't call myself, a cloistered academic. Nobody works half time in Haiti and Rwanda and all these other places.
Right.
That, but it was. I think I have to go back and read the interview, but I distinctly recall thinking about the political side of it that was just emerging, I believe, this past summer, where suddenly it is politicized to wear a mask, which again makes no sense from a public health point of view, right? Why should that be a political act? And, it was, that was probably the spirit in which I intended it.
You grew up, you mentioned your roots, and you grew up in Weeki Wachee, Florida, where I've actually been. I was there as a kid, and I was probably there when you were living there. And that's in Central Florida. And when you were growing up, I would call it rural Florida. What still remains of you today, of that young boy who grew up in Central Florida? What's still intact from that boy to that man?
Well, all of the things that I'm interested in now, I was interested in a lot of those as a kid in rural Central Florida. I mean, I'd never really been to a doctor, but I could tell you I wanted to be one. I hadn't heard of medical anthropology, but I'm sure I would have found that enchanting as well if I'd bumped into it in Central Florida. And I treasure my childhood and growing up there. It was, I didn't understand Jim Crow, or because this is the rural South.
Right.
This is not like Miami. I didn't understand Jim Crow, but I could see it playing itself out in front of my eyes. I had a lot to learn, and that would require the process of leaving Central Florida and getting to do some of the great things I've been able to do, like go to college or go to medical school or train as an internist or train as an infectious disease doctor or an anthropologist. So obviously I'm very different just through that process. Like going to Haiti as a 23-year-old and having that change your life so profoundly. I'm a different person than I was as a child. But, I look back and I can certainly see those same interests, as that I feel now. So I don't know. I have a real sense of debt to my parents, my brothers and sisters, my school teachers in rural Central Florida. A lot of cherished friendships too from those days. Anyway, if my friends from high school were here, they would say, "Oh, he was like that when he was a kid too." That wouldn't be true, but they would say that. They would see, the part of me that they recognized then in the person that they recognize now. I think. I mean, they've said that kind of stuff.
You said that you spent your time looking at this complexity of the system today of public health here in the United States. And Santa Clara County Public Health Officer Sarah Cody told me in an interview not long ago, she said that we have this public health system in the United States that feels like it's made of matchsticks and Scotch tape. We're trying to put this enormous burden on this pretty underdeveloped infrastructure, and not surprising, it breaks. If pandemic disease and epidemics tell us a lot about society, what are some of the social pathologies revealed here?
Well, first of all, Dr. Cody describes our public health system in perfect terms. It is like a vestigial organ. We put a huge fraction of our GDP into health care or health problems, but that's a lot of that is private, out of pocket, and the financing of public health is scandalous and has been for many, many decades, right? So it is Scotch tape, and it didn't hold, right? When we talk about flattening the curve, and when we talked about flattening the curve, of course, I've been through that many times. I'm sure Michele has too. In Ebola in West Africa in 2014, we were all about saying we've got to flatten the curve or it's going to wipe out the entire care delivery system. And it did. It wiped out the entire care delivery system. And really, we're seeing that here, right? And that's pretty shocking, to see in the United States. Now, it doesn't look the same, right? But I can tell you, at my hospital, the Brigham and Women's Hospital, what happens when, people aren't able to go and for an elective procedure or, to deal with a serious complication of diabetes because the hospitals, are shut down or closed or really consumed by responding to COVID. That's failing to flatten the curve. And so, there is that social pathology. What is it about us that would make us so stingy with our public purse strings in terms of safety nets, whether public health safety nets, unemployment insurance, the long, eviction protection. So the social pathology is actually not unlike a lot of what I saw growing up in rural Central Florida. We have a Jim Crow mentality that has seeped into all of our institutions. Whether we're looking at the southern border, or I've been lucky enough to work with the Navajo for some time, whether we're looking at reservations or meatpacking plants, or on and on the list goes. These social pathologies are really all around social inequality, and ours is very deep. Now, the good news is that social inequality can be addressed through social services, right? But what are those social services? Insurance, unemployment insurance, health insurance, protection from eviction, help with schooling, help with groceries. In Massachusetts, where Partners in Health is the primary partner with the public health authorities in contact tracing for the state, we've done some surveys just asking people, okay, so what is it you would need in order to isolate for 8 days, 2 weeks? And what are you running out of? 80% had food insecurity. 80%. I would have guessed it would have been a bigger mix, cell phone bills, rent, whatever. All those come up as well. But 80% food insecurity, that's a social pathology that's a reflection of a social inequality, but one that could be addressed rather rapidly.
Mm-hmm.
And so I think our social pathologies are social inequality, and they all have deep roots, and they vary from region to region in the United States, but they're around social inequalities.
As you look at the distribution of the vaccine here and throughout the rest of the world, what are you thinking about as far as equity in the distribution in the global South, especially? And how important is it to get a temporary suspension of intellectual property rights and patents so that vaccines can become more accessible, especially in the global South?
Well, one of the high school students asked me just that question. So a 16-year-old, and I didn't give a satisfactory answer. I didn't dither by reciting the numbers. Like right now, as we sit here, countries with about 13% of the world's population have already purchased or have purchasing agreement for more than half of all vaccines that are likely to be available between now and the summer. So that's a big problem, right? Because in a pandemic, how much time should we have to spend pointing out that, if we're not all protected, then it just goes to another vulnerable population. And we're not going to achieve herd immunity in a matter of weeks or months. And even when we do, we're still talking about many vulnerable people. So I think that the part that I had to dither on was how much the suspension of intellectual property rights matters. I'm sure that the answer is it matters a lot, right? The question is, do we attack that system, or is there a way to muster resources in the short order? Because I'm not. I've had to say this before many times, including to friends of mine in pharma and industry. I'm like, hey, guys, gals, I'm not attacking, the industry. I'm just saying it's not serving my patients in the way we need it to, right? And once we get beyond that polemic, I can have very meaningful discussions with friends whose real livelihood and chance for innovation, they say, comes out of patent protection. And you know what? I don't think they're lying to me, right? What I'm really saying is, are there circumstances, and what you're saying is, are there circumstances in which the rules have to be suspended in order to reach everyone? This is one of those circumstances. Which rules? I'm not sure. But there's no way that we can go forward when right now, with current plans for the next several months, we're not going to meet even 18, 20% of the need in a lot of the places where we work. And that's even true inside the United States. There are places where we're not on track really to address these social disparities in time to get everybody vaccinated. So I think we have to, rather than focus on one specific part of it, although I have no qualms taking on patent protection. I mean, in a conversation or in a protest or whatever else. I'm just saying, I know we're in a situation where rules must be suspended and normal bureaucratic practices must be suspended. I'm just not sure which ones they are and when. On many other aspects of the vaccine rollout, though, I do feel like I have some experience and expertise.
Let me go back to 2014. You were in Sierra Leone in June when Ebola began sweeping West Africa, and you left there. I think you were at a conference in Sierra Leone, and you went back to Rwanda and began seeing the terror that was unfolding. What was that early period like as Ebola began to take hold throughout Rwanda, Sierra Leone, and Liberia? Can you describe the terror that you saw?
Yeah. I mean, part of it is like, I'm embarrassed, right? I mean, I was there in June. I was there when the first cases hit the capital, Freetown. I mean, I'm dead sure, right? So I left knowing, and why would you go to Sierra Leone for a medical conference? And the answer to that question is because I helped to organize the conference. It was on, and many people from Stanford were there too, several people. The conference was about surgical care in resource poor settings. And so the first of 3 meetings we were doing, these big 3 meetings, the first was at Harvard and the third one was in Dubai. And I said, well, these are not really resource poor settings. I mean, Harvard is resource poor compared to Stanford, but, we really need to ground ourselves in the clinical desert.
I heard that, Paul.
You guys have a lot of assets, that's for sure. So we needed to go to the clinical desert, and that's why we went to Sierra Leone. We chose it. But the epidemic had already started. It was declared in March, late March. It was identified the cause of these sudden febrile deaths that began in the eastern parts of 3 countries, Guinea, Sierra Leone, and Liberia. And if you look at a map, they all come together in this really narrow firth of land in the eastern reaches of not too far from the coast, but again, those are the far eastern reaches of these countries which border the Atlantic coast in the west. So, when I say embarrassing, I mean, I'm not embarrassed that we held our meeting in the clinical desert. That's the right place to think about these issues, right? With our colleagues who had been facing a complete absence of modern surgical care, even for a C-section, all right? So, but the hard part was that we left. And it was clear that Ebola was going to, the surge would not be flattened, I would say, by the time we left, which was in late June. But the real experience for me was not when Ebola surged across the Rwandan border in the Congo. It was when a friend of mine died of Ebola. And it was like a slow motion. I mean, I say friend, he was a colleague, an infectious disease doctor from Sierra Leone. It was like a slow motion disaster. Every little thing you would worry about, you should worry about for every patient. But if you know the person, right, and you're thinking, oh my God, he has diarrhea and fluid loss and he needs an IV, that was July 29th. And that was really when I said, maybe I found out about it the next day, but we knew it was going to go badly. That's when I said, we should go back. But I mean, I hadn't even convinced myself until that happened. And I am very grateful that we did go back. But it was a very tough summer. So the real terror, Paul, that I saw was actually when we went back, because by then the surge had not been flattened. The cities had been overrun. First Monrovia, first Conakry in Guinea, although Guinea did a better job than they get credit for, and then Monrovia, and then Freetown. And I returned to Freetown not at the height of what was called the Western surge, but early in it. And so from then on out, it was all Ebola all the time, every day, everywhere, city, town, anywhere we went. So that was pretty terrible, and to see young, previously healthy people die of this disease, grueling, especially when they died of septic shock, which nobody should die of septic shock.
Two individuals are key to your book and inspired your book, and you write about them: Ibrahim Kamara and Yabum Kuroma. What is it about their lives that gave you the context to tell the larger story of the plundering of Africa by the colonialists? You use them as sort of metaphors, I would say, as to the larger issue of the decay, the destruction of Africa by the colonialists.
You know, I found myself getting choked up for a second, which is not a as Michelle will tell you, not a good sign. But these people, many of them patients, of course, over the years they become friends, and it's not easy to interview people about these matters. You know, I'll just flat out. So we have a book club that I didn't set up, and I'm thrilled. It's a book club about that book, and of course, people in Sierra Leone are on the book club. What else? It's a Partners in Health book club. Of course, there are going to be people from Haiti, Rwanda, Sierra Leone, Liberia, and those two, Ibrahim and Yabom, have been on the book club. And when I met Yabom, she hardly spoke English at all. I mean, that's not true, but her English wasn't well. She spoke English, but not like she does now, because when she survived, even though most of her family did not, what do you think she said? I want to go to school. I want to learn English, and she has, right? But you're right, Paul. I knew I was inspired to write that book by Ibrahim, and nothing that Yabom ever said to me made me less interested in writing about it. I just had a hard time writing about her life. Just remember that every adult patient that we had with Ebola, every one of them survived a brutal civil war that had ended only just before, just a few years, a decade before Ebola hit them. So, when you think about that, which we weren't thinking about in the middle of an Ebola treatment unit or a community care center or a hospital, they don't want us to be there to think about their post-colonial history. They want us there to provide medical services. And, I can't tell you how many of our colleagues who came, when they started going off about some cultural or historical fact, I would say, you know what, right now, we really just have to take care of the patients. We can talk about this later. Now, that I only said that to people I was close to, some of them from Stanford, I might add. And, but by the time I started talking to Ibrahim and then Yabom, Yabom was still a patient, but I thought, one of them, Ibrahim, had asked me to write about his experience. He had lost 22 members of his family in 1 month. And I was sitting there thinking, oh my God, I've never heard of a pathogen that would do that. Like, only time I ever saw that, war and an earthquake. And even then, to get 22 members of the same family, you have to have some pretty demonic kind of plan in mind. There have been them, of course, but I hadn't seen that in my experience. But, you asked about the history section of colonial rule and post-colonial rule. And, that's how I think about it. Just as you said, Paul, I think about, like, you want to learn about my friends, former patients, Ibrahim, Yabom, and all the rest of them in such detail and with so much intimacy that they were willing to share with me, so much that I could barely even face some of these interviews with them. I would cancel an interview and switch and say, let's just have lunch, or let's go to the hospital. That was just so I didn't have to continue the conversations we were having.
Too painful for you and too
painful
painful for them
and for them. But it was very painful for them, and kind of horrifying. And I thought back, was I this way as a graduate student in anthropology? I mean, I seem to recall a great deal more youthful enthusiasm for all kinds of devastating stories, but this was too much. And so, but I did do it. I continued, all the way through. It took me 2 years to get through those interviews with Yabom. Could have done it in a week. Would have been different. But I'll tell you, back to your original question, to me, if you want to learn about them, then the price of admission is understanding colonial rule and the way that racism plays out in colonial rule, and particularly colonial medicine. And I know I'd written, all my books are really about that in some sense, but don't forget, when you're writing about colonial rule in Haiti, you're either writing about the American occupation from 1915 to 1934, or you're going back to before the revolution. It's a radically different experience. In Sierra Leone, we're talking this in Africa, across the continent, this is 20th century experience. I mean, when I was born, they were all still colonies. So I thought, if I'm going to learn this about my patients and friends and share this, then we're all going to learn about the specifics of colonial rule and particularly colonial medicine. So that was the logic behind the book, almost the whole book.
You open the epilogue of the book by citing a quote by Dr. Roux, the protagonist in Camus' seminal work, The Plague. And he says, the only means of fighting a plague is common decency. Why did you choose that quote? What did you want to say there? I mean, the beginning of the epilogue. That's a powerful statement. What did you want to say about decency? Where do you see it?
Well, I see decency everywhere. So I'm not looking around, in the United States in the middle of COVID, or in Sierra Leone in the middle of Ebola, or a cholera epidemic, or an earthquake in Haiti. I see the decency all around. And, maybe I have a personal pathology that has me looking for decency, but I don't find it to be rare. I mean, just like teach a high school class to a bunch of 15 and 16-year-olds, the questions I got were not only sharp, they were kind of informed by a decency. But the reason I like that line, and I reread the book like 3 times in 1 year or 2 years. I read it sometime in 2014 in Sierra Leone. And at least I read it again when I was writing that epilogue, which was in the first days of April. And, or maybe the last days of March, I read the book again. Every page, it's not a big novel. And, I was so taken by the protagonist, even when I read it decades ago. Bernard Rieu is his name. And he's not an extraordinary person.
Mhm.
He's just decent. And, he says stuff like that. He's like, look, decency, that's just doing my job. And it's true.
You've seen death many years, many times. You saw it beginning as a young man in Haiti when you were there in the 70s before law school. And you've seen it in Ebola, and you've seen it throughout your career. I'm wondering if you see death differently now. Do you think of death differently now than perhaps you did 20 or 30 years ago?
No. The first time I saw a young person die, a young woman die in childbirth, I thought, this is a fucking obscenity. And I still feel the same way, and no less passionate about it. So, I understand the notion of a good death, right? I can certainly concoct a lot of ideas about my own exit, or another loved one who's, let's say, elderly and suffering. And of course, I've been involved in that kind of medical care as well. But, let me just put it this way. And I tried to do this in that book. If you look at parts of Sierra Leone, like the part where I was working, and my colleague, Eugene Richardson, one of Michelle's proteges from Stanford, he was there as well. It's a part of Sierra Leone called Port Loko, which is a town and a district. And I didn't even know that. I'm like, we walk out of a meeting with the Minister of Health, and he said, you're going to Port Loko. And I said to my colleague, Michele Barry, who some of you know at Stanford, my best pal in Sierra Leone, we're walking out the door. There's chlorine, acrid fumes assaulting us. And I said, where's Port Loko? Is that a town, a city, a port, a district? And he said, it's all those. And it's near the airport. That was all I got, right? And, when you look back at its history, which of course we didn't do during the epidemic, I would never, turn away from the task that we were called to do. I mean, I try to read and write so that I can learn. You know, I tell my own students, I think with my hand. It's better if I write it down. So I started writing about Ebola, well, years ago. There's a picture of, you know, an Ebola mass grave on Infections and Inequalities, which is from 20 something years ago, right? I mean, all infectious disease doctors are fascinated by it. But why? Is it really because it's so virulent, or is it the terrain that these people live in that's virulent? And, you know, you've read the book, so you know I'm saying it's the latter. And life expectancy at birth at the end of the war in Sierra Leone was the lowest in the world, maybe 34 years old. And in the last time a big pandemic hit Sierra Leone was, of course, the influenza pandemic of 1918. And at the end of that, the life expectancy was 34 years. So, you know, more or less, but I'm just saying, you know, that means that there's reason to be outraged by death that is different in 2014 than in 1919. It's bad enough in 1919 at the close of World War I, when they get hit by, you know, first a rinderpest pandemic that kills the cows, then smallpox, and then influenza, right? But think about the tools that we have now. How could we justify, you know, as a species of humans, how can we justify such a lack of progress for such large numbers of people? And indeed, that's what Partners in Health has been focused on from the beginning. And that's why we regard, many of us, Haiti as our best teacher.
You have a lot of students listening to you today. And on the one hand, they may be very optimistic about the world. And on the other hand, they may be daunted by its complexities, its complications, a lot of what we talked about. What do you tell them about the ability of one person to make change?
Well, I tell them not to bother with that too much,
Ah,
because I do, you know, because I don't have an experience of one person making a difference. I work with so many people, you know, and I think about people who do, you know, pole vaulters, novelists, you know, solo violinists, yo-yo ma. I mean, you know, in health and medicine and public health and certainly global health equity, it's all about teamwork. And so what I tell my own students is, look for the people you want to work with long term. Some of them will be your classmates. You know, for me, having gone to rural Haiti in the year between college and medical school, I'm still working with those same people. Some of them have died of old age, you know, since 1983. And I miss them, but at least they didn't die a horrible death at 30, you know, in childbirth. Back to the death question. So I tell students, do not think of this as a personal project. You know, this is one of the things, Michele and I have talked about this for years and years, because on the one hand, we tell our students, hey, pull together a proposal, you know, a research proposal with a hypothesis, and it's all you. But we really know that's not how it works. You know, we really know they have to fit into a community if they're going to make a difference. They should be humble. They should be part of a bigger project. They should obviously defer to their hosts, whoever they may be. So I think we give our students really mixed messages. Now, if you're a novelist, I strike all this, or a pole vaulter, or again, you know, choose something that you can do on your own. You still have a coach, you still have teammates, I'm sure, but healthcare, medicine, public health, health and social justice, all teamwork.
let me ask you a final question. Do you think about how you want to be remembered? Do you care about how you want to be remembered? And when you think about your tremendous accomplishments, your successes, and maybe even your failures, what stands out? How do you want to be remembered?
Michele, you're right about this guy. He's good. Paul, you know, let me put it this way. If I imagine a tombstone would be like bad, right?
Maybe not.
But if there were one, I would just wanted to say he was of use. That's all I want. And, you know, Partners in Health, and Michele is lovely to point out that like any endeavor, it's large. I mean, there's like 20,000 employees in a dozen countries, but it started out with a passion from a small group of people, but it wasn't the passion that was really remarkable. It was just that we said we're going to keep doing it through good times and bad, through coups, through financial reversals, to loss of funding, epidemics, of course, earthquakes, fires, arson, lots of bad things, but if you can stick with it, you could say, I was of use. Again, I would tell people, if you want to be remembered for kindness, be remembered for being useful to others. And Martin Luther King said it so much better. He said, anybody can be great because anybody can serve. And I take that to heart very deeply. I believe it. I believe some people can serve through being a nurse or a doctor, and some people can serve by being a teacher or a great communicator or a great writer. But being of service is something we should continue to cultivate in our students.
Thank you so much, Paul.
Thank you, Paul.
I'm going to open it up now to questions. And I've been sort of trying to curate some of the questions, and I'm going to start from the beginning. It's always hard to follow you, Paul, after you open your heart, and I really respect that so much.
Thank you.
Anna Ursalis asks, and this should come from your heart as well, I'm sure, is how do you keep yourself from becoming jaded by medicine and all the deaths that you see around you? How do you preserve the joy of medicine and navigate physician burnout?
Yeah. Did you say Anna?
Anna.
Anna? Mm-hmm. Well, Anna, thank you for the question. And again, I'm going to start with the obligatory but very sincere and heartfelt argument that we really need accompaniment from our friends and family to do this work. And it can't be about, your quest for personal efficacy. It has to be about, how can I be part of a team doing tough work, right? And I could have said to Paul, in response to his question about death, is I don't find it any easier now than I did 30 years ago. Mm-hmm. All I can say is I've seen a lot more of it, and it's still ghastly. And so I don't want to be a different person who is jaded, but it's never happened to me. And there have been times when I have retreated, where I've just said to my closest friends, and I'm embarrassed to say this too, I can't deal with this today. I can't take any more. And then I always have coworkers, and Michele knows many of them, who will come in and say, that we got you. You're not on call tonight. You're not doing this tonight, right? Now, that said, I'm going to say, I believe that this is the most cheerful branch of medicine and public health for lots of reasons. One is you get the satisfaction of knowing that you were of use because you're actually doing something where maybe there hadn't been ready access to that service before. And that's a task before us in parts of, Silicon Valley. There are right next to Stanford, there are areas, you've heard this a million times, so I don't have to repeat it. But here's the other thing I want to say. Most of our patients are young and they mostly get better. You got obstructed labor. Is there therapy for that? Yeah. You got childhood leukemia. Is there therapy for that? Yes, there is. You got AIDS. You have something for that? Yes. You have Ebola. So the act of performing global health equity, that is a material intervention, I was of use, we were of use is better, has stunning results in the middle of a clinical desert. It's in the middle of a clinical desert that you actually see the real power of medicine and public health, in the middle of a clinical desert. That's where you can see it. You go to a place, and again, Michele and I have been to many, a lot of these places that I'm talking about. I'm sure many of those listening have as well. You go to a place that's a clinical desert, there's no staff, there's no stuff, there's no space, and there's no systems. And you put in a little bit of staff, stuff, space, systems. That's where you get the real return on the promise of the technological promise, for example, therapeutics, preventives, diagnostics. This is work that is fundamentally cheering. And a lot of people, the first thing they say is, how do you deal with all the death? And I say, we deal with the death by treating it before they die, and that's very satisfying. Now, when we fail, it's very painful. And that happens. That's why you need people around you in order not to be jaded or worse. There are worse things than jaded, wounded, despairing. And, I think that this is the kind of work where actually despair is less common because,
I agree.
and Michele, please
Yeah.
feel free to chime in at
Oh,
any
no,
point.
I think it's all about our teams that keep us going. I'm going to just move on to another question, Paul, because there are like many questions here. And I'm going to combine a couple of them. There's several questions about public health. Christine Kurahara asks about, would it help our fractured nation to institute a year or two of required service for 18-year-olds? I think people need to get out of their bubbles. What do you think? Christine Gabali asks, is the word public in public health the issue that makes it anemic? And then I'm going to add to those two things about public health. After the Flexner report, public health and medical schools were separated. What are your thoughts about that, Paul, that schism? And how do we fix that, or should we
Well,
fix
I know that's a lob because you and I have been talking about this for 25 years and then some. But let me just say to Christine asked the second question. Who was it? Also, Christine?
There are two Christines,
Two Christines, I thought.
the 18-year-old service.
Yeah,
And
I'm all for it. And let me give an example. I also think we should have a national service corps for people who are my age or halfway between 18, I'm 61, halfway between 18 and 61. And let me just give an example, again, one that several people on this call could give. When the Biden administration, which I regard as fundamentally not hostile to any of this stuff, but on the contrary, when the Biden administration started talking about contact tracers and a public health corps, I was like, yay, that would be great. Bring on WPA. And I don't mean Women, Poverty, and AIDS are not best-selling book, but what was WPA? WPA is public, anyway, FDR. When you hear about 100,000, it's like Rwanda has 100,000 contact tracers. But they have 12 million people. They've already mustered that. And when I went there, I was like, holy moly, everybody's wearing masks, social distancing, they're doing contact tracing, and people, my friends in the United States, including, colleagues, would say, but, we're just overwhelmed and beleaguered, there are too many cases. And that's true, but we still have to do contact tracing to get down from that mountain. So we're going to have to do it. And 100,000 is not the scope we should be thinking. Now, should they be 18-year-olds? I don't know. I think not. But that doesn't mean, and I'm not sure, by the way, but that doesn't mean we don't need this National Service Corps for the reason that you say. I think it would be a very welcome thing. I do think a lot of middle class and elites believe that about their own children. I mean, it's rare that I get an applicant to Harvard college or medical school where they don't have a pretty robust service record. I'm still wondering how I got into those places. But, I also think we need that big National Service Corps. And,
can I just intervene to just say Gillibrand is putting out a bill, and I know Partners has supported it, for a workforce, a public workforce. So
and we're very excited about that.
Yes.
And I would just say we, Partners in Health, but lots of other people. That gets to the second Christine question. Public health, is it the public part that makes it anemic? Yeah, in the United States. But in Rwanda, they're putting like 20% of their public treasury into healthcare, both delivery and public health. 20%. That's probably more than just about any place on the continent. That's like Cuba levels, right? And, you could say, well, the United States puts almost 20% into health. No, that's care delivery, and all includes out-of-pocket expenditures, et cetera. So the public health approach is anemic in places where there isn't public investment. And, another thing that I want to say, and I know, and I'll go back to the Flexner report. Actually, let me meld that. So I've stopped, I use the term public health a lot, but when I'm thinking about the public health I'd like to see, I say global health equity. Whether it's in Detroit or Dubai, and there are needs in Dubai too. Think about all the Filipino workers there. I could go on and on, but I'm saying global health equity, seems to sum it up, right? Stanford's on the globe, Navajo's on the globe, Sierra Leone's on the globe, Dubai's on and on it goes. And then without the E word, equity, I've just seen how often our public health interventions get dumbed down for poor people. Not just dumbed down, but it's not like Tuskegee level, right? But it's like, how can we do the least possible for the most people? The public health logic of when Michele and I met, the public health logic of the 80s was really all about neoliberalism. And we didn't even have the words to say that. We didn't even know what neoliberal, we didn't, I bet I didn't know how to say it, but that's what it was. So the Flexner report, when it separated public health from medicine, I think one of the costs of that was not that. The one that the public health people I know always talk about is then all the power went to medicine and public health got shafted. It's rare. I'm a public health person, so I'm going to say it's, we are often a very self-pitying group. Like, no one cares about us, no one funds us, it's all going to medicine. And, I feel like saying to self and others, yeah, well, maybe if your aspirations were a little more focused on equity and something bold, then we'd be more enthusiastic, right? And so I think the Flexner report, one of the, I think that split, one of the problems is public health people are just too divorced from any kind of service to the sick. If they were nurses, and some of them are, we'd be safer, right? The best public health people I know are nurses, right? They're the TB nurses and the public health nurses, and they don't forget that some people do get sick, and it's not all about prevention, and they don't forget prevention. So I think we need to really push for global health equity. And, whether we call it that or something else, that's the key, I think, is the equity piece in the United States and elsewhere. Although the United States deserves ample focus.
To follow up on that is a question from Meredith, where she asked, what do you think the US should learn from LMICs, and how can we better exchange ideas from the South to the North?
Yeah.
I think that
Well,
follows up on what you're.
let me say one thing that'll please everybody, and another that might be seen as tendentious or inflammatory, but it's not. The one thing, and again, you and I have discussed this a lot over the years, but if you point, as we did, to the governor of Massachusetts, if you say, hey, you know what, we've had some experience with this in Haiti, Rwanda, Haiti, Rwanda, and recently Sierra Leone and Liberia. Our colleagues there have taught us how to do contact tracing with appropriate support. We know something about social distancing. We know a lot about, so really that's how we sold ourselves to the state of Massachusetts, was to say, we're bringing something from Rwanda. So, and you know what? They said, yeah, we get it. The governor, his Secretary of Health and Human Services, they said, like, we're thrilled that these ideas come from Rwanda and Haiti. We don't care. Let's just bring it on. So, that was, an important part of the intervention, and whether we call them LMICs or something else, those ideas for us in that experience came particularly from Africa, and we brought it to Massachusetts. And
So that's a great example. We only have a couple minutes, so I'm just going to throw a couple more questions at you. Annie Trumbull asks, and this is a good question, how do you pick a global health cause? I feel torn and drawn to so many different projects. Annie, I feel that way. And I'm wondering, how do you hone in on one area, Paul?
Well, first of all, there is both a personal and collective part of that, right? So the personal part, which I would encourage you, Annie, to do some soul searching about the kind of stuff that you like to do the most, because it's, as I mentioned earlier, it's necessary to sustain the engagement. It's hard to do the sustaining if you're not into it. For example, I discovered in my last year of college that I loved medical anthropology more than I loved biochemistry. And so even though I didn't get to take a lot of medical anthropology in college because I discovered it late, I became a convert, and not to the discipline, but just I liked that way of doing things, right? So remember to choose something that you like, right? And the other thing is, sustaining your engagement over time requires that. So I just want to encourage people listening to understand that there's no one answer to that question. But since you ask how I do it, I'll tell you, it's very straightforward. I look at two things: the burden of disease and the gaps. Now, I'm not suggesting that the burden of disease is easy to assess, right? It requires a lot of tools that are rarely brought to the places that have such high burdens of disease, right? So much of this is really extrapolation, guessing, and you should read our shared student, Michelle's and my shared students, Eugene Richardson's new book called Epidemic Illusions. And it's a shocking takedown of the ways in which epidemiology is used and misused. But it is not impossible to say, okay, hey, in this squatter settlement in Haiti or in this city in California, what are the top 10 causes of young adult death, of children's death, of women's death? That kind of project assessment is essential if you're trying to hone in on something, I think. And the other is gaps. Like, for example, before 2002, you'd be hard pressed to point to a single publicly funded AIDS treatment program. So between the development of effective therapy and PEPFAR, which, I mean, I can't speak for Michelle, although I'd love to right now. I think she was shocked as I was when George W. Bush created the most important health diplomacy and life-saving intervention in the history of global health from this country. And tell me the French, German, and British, come on. The colonial regimes never did that. They had control over care as their mantra during all of colonial rule. So that was an example, not just a burden of disease, because HIV was the leading infectious killer of young adults in the world, probably, certainly in the United States and the countries in Africa where most of the programming occurred, but there was no program to take care of those people. So there was a gap. So if you can combine in your life those three things: one, an avocation or a joy in the work; two, an understanding of what the ranking problems are; and three, which ones are being neglected, right? So if someone says, oh, don't worry about climate change, everybody's paying attention to that. That's not true at all, right? So there's a big gap there. Right? Or you could say, what about cancer care in rural Africa? You can't say, oh, everybody's paying attention to that. That's false. So I think using those three intersecting axes is a great way to find something that would be meaningful for years to come.
Well, thank you, Paul, both Pauls, to the interviewer, Paul. And I'm sorry we didn't get to all the questions, but maybe we can.
Oh, I just see a note from,
Well,
hello, Mrs. Bash. Sorry, go ahead. I shouldn't have looked at these.
yeah, there are many, Paul. Let me just, but I just have
just
to
saw
say,
them.
to Paul Costello, it's a joy to see
Paul.
how you are able to draw people out in interviews. And to Paul Farmer, it's really always humbling to hear you share your perspective on how to make a world more equitable. So thank you both, Pauls.
Thank you, Paul. You got me choked up there. I don't like that usually, but
This is a tough one, Paul Costello, to have done. So anyway, I wish everyone well and be safe and change the world. Thank you very much.
thank you so much, all of you, for having me.
Oh, it's our honor.
Thank you.
Bye-bye. Talk to you later.
Bye, Michelle.